The Institute of Medicine estimates that a third of the money that we spend on healthcare does nothing to improve health. And as we've talked about, a lot of that's administrative, but there's also inefficiencies in the delivery system. About 20% of Medicare admissions to hospitals are readmissions, and many of them are likely unnecessary. Can you talk about what in this bill is going to address those delivery system inefficiencies?
The bill as written has several reforms in it. Part of that, I think, is going to be one of the biggest inefficiencies, frankly, has been in the administrative cost area in administering private health care plans. And I know the large employers that are part of your coalition, they spend inordinate amount of time and resources trying to negotiate with these large health care plans. This is going to actually, I think, give them a lot better leverage, because in the basic benefits package, they're going to have to include a lot of these things that have not been included in the past. They're going to have to get rid of some of these discriminatory practices. And so I think it's going to give better leverage for businesses and, frankly, better choice for their employees. If they want to keep their plan, or if they want to shop in this marketplace of the exchange for alternatives.
I guess, though, I'm referring to complications, readmissions, medical errors, things that are problems within the delivery system. We've talked a lot about how we finance the problem, but we still have exploding healthcare costs that we need to control. So,
with regard to quality measures, it's important that we look for those best practices. I know there are pilot programs within the bill, and again, to be able to identify, we've seen big disparities. There's an article in one of the publications, I think in the past week, comparing cost of the Mayo Clinic to clinics in LA, and they were in LA it was almost double for the same basket of services. So if we can identify those kind of best practices where they're actually showing higher quality care and outcomes at almost half the cost, it's a great model for how we can achieve those things. And I know there's some folks on the panel that are going to want to weigh in on this, and I'm going to have to take off here in just a few minutes to catch a plane back, but I'm going to ask if the folks at the panel might be able to stay a few minutes longer, and perhaps they can answer some questions as well. But let's ask the panelists to also respond to your question. Daniel?
Very quickly, as you might be aware, there are things in this bill that deal with readmissions. Dealing with preventable readmissions, it's important to look at the ones that are preventable, not just all. And also an expansion of the current value-based purchasing program, which is not new, but it will get greatly expanded in this, both on the Medicare program and also in this new public option is there as well.
There's also a provision to set up a new commission to look at clinical effectiveness. One of the articles in the press last week pointed out that in terms of prostate cancer treatment, we don't really know whether waiting and watching may be just as effective as some of the very aggressive, very expensive treatments we're using. And the idea is to set up a blue ribbon panel that involves clinicians and scientists to figure out what works and to pay for treatments that work rather than the way we do it now, which is often just to pay for what's new, and that often means expensive. This could be an important cost saver in the system and also improve our outcomes and our health.
All right, I'm going to take two more. I'm going to go to the back and then to the front. Yes.
I'm Pat McHugh. Thank you for the meeting. I am really concerned that the for-profit companies are running this discussion. They're playing nice now, but I cannot believe they want to sacrifice their profits. Now, I say for-profit, just that with healthcare is obscene. This is not to say that doctors and medical professionals should not get good, maybe above average wages. I mean, good wages. This is not what we're saying. But nobody should be able to take home, say, $231 million as a CEO. Now, the single payer off the table. It was never on the table, and that was engineered by these companies. Now, oh, it would be so disruptive. Well, think back to when Medicare was adopted. Oh my God, the world was going to end. A year later, everything had settled out, and people were happy with it. Medicare has been a wonderful program until lately, when the for-profit companies have gotten their claws into it. And I'm afraid, I will fight if all we can get because of this mess is an option. But I'm afraid the sicker, the poorer, the uninsurable will be in that low-level program, and the others will be somewhere else. We need a single program. Chicago alone has 1,700 providers. This is nuts. Even if they all had the same paperwork. All right, people say, well, oh, the government will decide who is going to get care. Well, right now it's some secretary with a high school education sitting at a desk who's asking the doctor, what does that mean? What is that disease? And then denying it anyway. So I'm saying we have to get single payer on the table. That, people could go out and spend extra money for private doctors also. But to graft this onto what we have is not going to work. 3 years, 2 years, 3 years, it collapses and we'll be in worse shape. Let's have welfare for all of these workers that are working for these healthcare companies. Let's give them a lot of money for 2 or 3 years. We would still save it in the end. This is nuts. Thank you.
Thank you. Again, as several here have stated, and I have, the single payer, although many feel strongly about it, that is the ultimate answer, that is not on the table now. But I do believe some of the important elements behind that can still be achieved with the public plan, and that's why I think that's so important, to be sure and continue to drive costs down and have that public option. And you are correct. The for-profit health insurance companies have been some of the most seriously opposed to the public option, but I think that's also been part of the reason that they have come to the table to finally give some concessions that for years and years they have not done. So I think it's been a very important part of this debate and an important part of the change. Any comments from the panel? Daniel.
Just very quickly, it's probably important to recognize there's a difference between single payer and universal coverage. Most of the world, as has been pointed out, has universal coverage. Relatively few countries, namely Canada and Britain, have a single payer system. They are not synonymous terms.
Yes, front mic. It's going to be my last question, and I'm going to have to run to the airport. But as I said, if some others have comments, we certainly want to hear them.
Thank you very much for taking the time to listen to me, Representative. My name is Dr. Steve Rudensky. I am a retired radiologist, and I represent Missouri Healthcare for All. We are a grassroots, faith-based organization that now has 106 organizations behind us and thousands of people that are doing what you want to do. Let me tell you a few things, some things that only a person inside the system can tell you and that nobody has ever talked about. Because as a physician, I know what goes on, and nobody else can understand this unless you're in the system itself. Nobody on the panel there can even understand this. Because unless you're a physician, first of all, 10 people die every week in Missouri, 40 a month, 480 a year. That's equivalent to a jumbo jet crashing in every state of the United States. What are those lives worth?